PG working in GMC Nandyal now. She did her UG and PG. She's been a teacher for UG and PG and APOG treasurer for the year 2018, and she's been a speaker in various CMEs and APCOG 2018. Paper presentation in AICOG in 2011 and 19, and poster presentation in Yuva Foxy 2018. And she's been a panelist and been in multiple CMAs. She is a faculty in Zonal CMA, Shantiram Medical College, Nandyal 2024. That's the South Cone Conference. We welcome you, ma'am.
Thank you for the mention of unknown location. It is a term used to describe the clinical scenario in which a patient with a positive pregnancy test has a transvaginal scan that shows neither an intrauterine pregnancy nor an ectopic pregnancy. So it is not a final diagnosis but rather an entity that requires continued evaluation until a final diagnosis is obtained. First of all, we should have some differential diagnosis before entering to find out the case. That may be an early intrauterine pregnancy or an ectopic pregnancy, molar pregnancy, and we should keep some rare entities in our mind, like invasive mole, choriocarcinoma, or some HCG producing tumors, heterophilic antibodies. It may be a laboratory error also. Heterophilic antibodies are large molecules that are not present in the urine, but it should be considered the possibility if the HCG test is positive in the blood but negative in the urine. In these cases, it is necessary to use a heterophilic antibody blocker for the correct diagnosis. As we will be evaluating the case from the history, the same thing has to be followed. History and physical examination, menstrual history, risk factors for ectopic pregnancy, if present, has to be evaluated along with the abdominal and pelvic examination. The incidence of PUL varies from 8 to 10%. The international consensus of ultrasound in obstetrics and gynecology determined that units specialized in early gestation should strive to maintain a PUL rate below 15%. They have classified the transvaginal scan findings in 2011 into 5 categories. It may be a definite ectopic pregnancy, or Category 2, probable ectopic pregnancy. Category 3, as pregnancy of unknown location. Category 4, probable intrauterine pregnancy. And Category 5, intrauterine pregnancy. Transvaginal scan is able to identify an EP with a sensitivity ranging from 87 to 94% and a specificity of 94 to 99%. Regarding the PULs, a common mistake is to perform transvaginal scan alone, but the adnexum might be located in a higher region, and hence a pelvic abdominal scan enables visualization and identification. So, while evaluating a case of PUL, both transabdominal and transvaginal scan has to be done. It is divided into pregnancy of unknown location. It may result in 4 possibilities. It may be an intrauterine pregnancy, which constitutes 30 to 47% of the cases. It may be a case of failed pregnancy of unknown location. In this case, the spontaneous outcome of pregnancy is HCG negative, but the exact location of the gestation is never identified. These cases are usually small ectopic pregnancies that are not visualized on ultrasound or represent the retention of the products of conception in the endometrial cavity with an active trophoblast. These cases constitute 50 to 70%. The IUP and failed PUL represents low risk. Ectopic pregnancy, 6 to 20% of cases. All the cases of PUL should not be considered as a synonym of ectopic pregnancy. Persistent PUL, 2% constitutes persistent PUL where the HCG does not decline spontaneously and abnormal increase or plateauing occurs. Persistent PUL is not a diagnosis and its outcome depends on whether the EP not visualized or it may be a treated pulp. In this case, methotrexate is administered without confirmation of location of pregnancy. Dissolved pulp, in this case, HCG titers are negative after expectant management or uterine evacuation, histological with histological evidence of chorionic villi. Follow, the only valid biomarkers are beta-HCG and progesterone. HCG, a single serum dosage cannot use to predict the outcome of PEL. The discriminatory zone indicates the value of serum HCG above which an intrauterine gestational sac will be visible on ultrasound. This value varies across various centers and it depends on the resolution degree of the ultrasound, the examiner's experience and the HCG kit used. 99% probability if the HCG reaches 3510. If the HCG is less than or equal to 3500 and there is rise of more than 66% after 48 hours, it may be a likely IUP and transvaginal scan to be repeated in 1 day. If the rise is less than or equal to 66%, if it may be an intrauterine pregnancy or an ectopic pregnancy, so HCG and transvaginal scan along with serum progesterone to be repeated after 48 hours. If the fall in HCG is more than 15%, it may be a case of failed PUL, so urine HCG to be repeated after 2 weeks. If the HCG is plateauing, then less than 2000 HCG after 48 hours along with transvaginal more than or equal to 2000, active management has to be taken. If the serum HCG values are more than 3500 and the rise of HCG after 48 hours is in between 15 to 35, active management has to be taken. If the fall is more than 15%, it may be a case of failed PUL, urine HCG to be repeated after 2 weeks. If HCG titers plateaus, active treatment in the form of MVA to be performed under local anesthesia. The material has to be sent for histopathological examination. If the HCG concentration does not drop by 15%, then intramuscular methotrexate to be used. In case of failure, chest, abdomen and pelvic examination via CT MRI to exclude the possibility of HCG producing tumor before starting a second cycle to be done. Reasons for non-visible gestational sacs with HCG values above the discriminatory zone are multiple gestation, ultrasound resolution, obesity, uterine fibroids, polyp and HCG standardization. The expected rate of rise is dependent on the initial HCG levels. If the HCG level is less than 1500, there will be 49% rise. If it is 3000, 15 to 3000, 40% and more than 3000, 33% rise. So, the HCG ratio is used to overcome all these problems. The ratio of serum HCG levels at 48 hours and 0 hours is called as HCG ratio. A ratio of more than 1.6 is predictive of viable IUP. Less than 0.87 spontaneous pregnancy resolution. If the ratio is in between these two, the possibility of ectopic pregnancy or persistent PUL increases. The progesterone, single serum progesterone value can be seen. P levels below 5 nanograms, non-viable gestations above 20 nanograms correlated with viable. Logistic regression models have been described to reduce the number of visits, laboratory draws and ultrasound assessments. M4 models use the HCG ratio and log of the average HCG level. It classifies PULs as low risk and high risk depending on the EP incidence. Low risk cases has to be followed up with urine HCG test in 2 weeks. For high-risk cases, TVUS is performed along with HCG levels every 48 hours. M6P model first uses serum progesterone followed by HCG. If the progesterone level is less than 2, then low risk for ectopic and urine HCG test, it is to be repeated in 2 weeks. If the P is more than 2 nanomoles per liter, it receives a second test that examines the HCG ratio. Other biomarkers are also explained, but to date only inhibin A has predicted PUL progression. Serial transvaginal scans 3 to 4 days intervals to facilitate earlier diagnosis. Surgery, a lack of visualization of the intrauterine gestational sac together with HCG values above the discriminatory zone was considered an indication for laparoscopy. Uterine evacuation or manual vacuum aspiration has been used primarily to differentiate EP from non-viable cases of IUP. So what are the advantages? It avoids methotrexate first of all, and the presence of chorionic villi in the uterine evacuation material is used to diagnose non-viable IUDs up to 20% of the time. However, HPA does not show chorionic villi. So HCG test, serum tests are done immediately before evacuation and 24 hours afterwards. If HCG titers decrease by at least 15% after uterine evacuation, it is diagnosed as non-viable IUD. If the HCG values stabilize or increase, mostly it is the ectopic pregnancy and the patient has to be treated with methotrexate. As you know, methotrexate is a folic acid antagonist. At least 3 months before becoming pregnant, after taking treatment 3 months, you should avoid conception. And management of persistent, active management rather than expectant management may result in more successful resolution of the pregnancy. Thank you.
Thank you, Sudha. That was